Good morning, everyone. It is 6:30. So, Monday 6:30, new topic. And today's topic is methadone. And methadone, our speaker is Dr. Sachin, who is the third year junior resident from Tata Memorial Hospital. And when I saw his area of interest, I was really happy that even the youngsters have such a brilliant area of interest they choose. That cost of cancer care, lung cancers, and the impact of cancer diagnosis on social life of patient and their caregivers. Excellent, Sachin. So I think it's an area which is really unexplored about the cost of cancer care and how cancer diagnosis impacts social life. Although there are many publications, but structured message from India still we are waiting. So thank you very much. And the moderator is Dr. Prasun. We have heard Prasun in the last lecture also. We have introduced, but I want to introduce today again. As Dr. Jayata is not here today, so I'm introducing both the speakers of TMH. Prasun is senior resident after finishing MD. He is senior resident in Department of Palliative Medicine at TMH. Oh, he got distinction in MD Palliative Medicine. And he is recipient of late Dr. Narayan Visaria Gold Medal and Dr. R.P. Bhandarkar Awards Surgery Gold Medal Pharmacology in Pediatrics. My God, you are so brilliant, Prasun. And he is member of Palliative Care Clinical Study Collaborative University of Technology, Sydney, Cancer Symptoms Trial, University Technology, Sydney, Multinational Association of Supportive Care in Cancer, and PACCSC Cardiovascular Disease Stroke Researcher. Very good. So he is already started collaborating after receiving so many medals from India. He has also already started collaborating from international agencies. Excellent person. And now one more is participants of ACORD PWD P2020. Very good. So Prasun, after seeing your both Prasun and Sachin's CV, I think I'm really excited to listen from both of you about methadone. Methadone is a topic which is really remain unexplored because we are not in a habit of using it is very frequently. So please listen carefully. If you have any doubt, please write down in the chat box. What I see after the lecture, that I don't get a lot of questions from residents. These lectures are mainly from youngsters and residents, but I don't see. And then finally, we will listen our seniors, those who are joining, that what are their experience on methadone. So go ahead, Sachin. Thank you very much.
Thank you. Thank you.
Your slides are visible, Dr. Sachin. Go ahead.
Yes. Thank you for the kind introduction. So, good morning, all. Today's topic for presentation is methadone. Let's start. So, objectives for today's topics are to know about the chemical nature and class of methadone, to know its mechanism of action, indications, pharmacokinetics, pharmacodynamics, the possible routes of administration, adverse events associated with methadone, special considerations of its use, and what is current evidence for its use. So methadone, chemically, it belongs to the class diphenyltryptane. The diagram is showing its molecular structure, and it is a strong opioid with analgesic with mixed properties. So by mixed properties, what we mean to say is it is a mu receptor agonist, also has some delta receptor agonist action. It is a N-methyl D-aspartate agonist, and also it exerts a presynaptic blocker action on serotonin and noradrenaline reuptake. So basically, it exists in a mixture of two enantiomers. the R enantiomer and S enantiomer. The R enantiomer has got analgesic properties, and it basically exerts its action on mu and delta receptors, and it is responsible for most of the adverse effects. And S enantiomer is an antitussive NMDA antagonist. It has got some SNRI action also, that is serotonin noradrenaline reuptake inhibition, and it has more potent effect on the cardiac conduction. So this diagram here depicts the action of methadone when on different neurological levels. Like we can say, there are we have in previous IAPC lectures we have seen the basic physiology of pain, how pain pathways are conducted. There are ascending pathways and descending pathways after some inflammation or injury is inflicted. So when there are mu receptor, so methadone while acting as a mu receptor, you can see how it is acting at the spinal cord level. Then the signals are conducted to the sensory somatosensory cortex, to medulla and midbrain. So there we also get in a ascending pathways, we also get the action which is NMDA receptor antagonism and delta receptor agonism. While in case of descending pathways, we have this SNRI reuptake inhibition effect, which helps in pain modulation and mood stabilization effect of the methadone. So this chart explains about what clinical benefits we can derive from the various methadone action. Like for the mu receptor agonism, we get the strong analgesia, analgesic effect, and it also helps in dyspnea. Then from delta receptor agonism, we derive strong analgesic action. NMDA receptor agonism helps in neuropathic pain and antitussive effect, and the presynaptic blocker of the serotonin reuptake inhibition, that is causes improvement in the mood. So various indications for the use of methadone are moderate to severe pain, alternative in cases of intolerance to other strong opioids, poorly responsive pain with other strong opioids, or in case where we have already used some adjuvants also, pain relief in severe renal impairment, and treatment of the opioid addiction. So coming to pharmacokinetics, it is a non-acidic lipophilic drug, and it has got high volume of distribution with only 1% of drug which is available in the blood. So there are different possible routes of administration can be used: oral, intravenous, intramuscular, subcutaneous, sublingual, rectal, or the last two are not that practiced that much often. So if you see here the oral bioavailability, 80%. The range has been given as 40% to 100%. You know, this wide variation in the bioavailability is partly because of methadone is a substrate of para-glycoprotein also, which is a form of where it is a form of protein where it is point bounded also. So that's why there is a wide range of variation. Also, if you compare this oral bioavailability to other opioids like codeine, it is 40%. For tramadol, it is 60 to 70%. But say morphine, a strong opioid, it is around 35%. While buprenorphine, the sublingual bioavailability is 29%. And for fentanyl, it is the sublingual availability is 55%. So in this particular scenario, methadone is quite helpful with high oral bioavailability. Also, it starts, the onset of action is around 30 minutes. For intramuscular preparation, it comes to 5 to 10 minutes, and it is 1 to 5 minutes for IV and subcutaneous administration. So faster onset. Then time to peak plasma concentration is around 4 hours for per oral administration and 1 hour for intramuscular administration. It is highly protein bound, around 60 to 90%. Plasma half-life is highly variable. Mean is around 20 to 35 hours with again a wide range of 5 to 130 hours, and it may be longer in older patients. And duration of action is about 4 to 5 hours per orally and 3 to 5 hours for intramuscular. 8 to 12 hours with this duration of action goes on increasing 12 hours with repeated doses. So when given in repeated doses, it tends to accumulate, and long plasma half-life has got due to high protein binding and the high volume of distribution. So implication of this is it takes around 4 to 7 days to achieve a steady state in the body, and accumulation may become a potential problem. So we have to be cautious while describing. Pharmacokinetics, primarily it is metabolized by CYP3A4 and CYP2B6 system. Some through CYP268, 2C9, 2C19, and 2D6 isoenzymes too. It has got biphasic metabolism. Like the first phase of tissue distribution is there, which is a slow phase, and that is followed by a slower metabolism phase. The metabolites are largely inactive. The excretion is mainly by the intestines and kidneys, and through renal excretion, most of the unchanged drug is excreted. Renal and hepatic impairment do not alter its clearance. Still, the caution should be exercised while prescribing in such conditions. So it would be prudent to reduce the initial dose by changing to 50% and titrate according to the response. So this chart explains about the various drug interactions. Methadone is increased by SSRIs, cimetidine, ciprofloxacin, diazepam, itraconazole, fluconazole, voriconazole, like many of the drugs which we use in common practice. It can be decreased by drugs like phenytoin, carbamazepine, phenobarbital, rifampicin, and antiretrovirals. There are certain drugs which are the levels of which may be increased by the method, like desperamine, sidovudine, and some of the drugs whose level may be decreased by methadone, like Empren. Different setting. This is now the different settings.
Sachin,
Yes, sir.
can I interrupt you for a minute? There's some background noise which is coming. A fan or something. Like
Yes, yes.
Please.
Is it fine, sir?
Yeah. Okay.
Yes, sir.
Please continue.
Yes. So let's now see some different settings where we do use the methadone for cancer pain. For cancer pain, it can be now, as the evidence is accumulating, it can be used as a first line or as a second line or as a co-analgesic also. It is relatively an inexpensive drug, and also provides it has the advantage that it provides comparable analgesia to other strong opioids. For patients who experience, say, inadequate pain relief with other strong opioids, maybe may not have faced undesirable effects, but still having inadequate pain control, we can use methadone. For patients who are having intolerable side effects with methadone, like the more adverse effects like opioid neurotoxicity with morphine, we can surely switch to methadone. But while doing so, the cautions about the titration of the methadone dose should always be exercised. And if expertise is not available at any center, then it will be prudent to use other stronger opioids like fentanyl, for that matter, with which some experience might be available. As an methadone can be also used as an alternative for strong opioids in patients with severe renal impairment, like in such setting of renal impairment, the treatment with morphine may not be feasible due to accumulation of toxic metabolite like M3G. So in that case, we can switch to methadone. In former opioid addicts who are being maintained on methadone, then it can be used for cancer breakthrough pain. Those there are two trials which are in favor of the use of methadone in cancer breakthrough pain, but still the evidence is not sustained for its upfront use as a breakthrough pain medication. It can be used in two forms, like sublingual form and or peroral form. The average time for meaningful pain relief with peroral form use is 30 minutes and sublingual use is 10 minutes. Then other settings which we are going to see in details are opioid-induced hyperalgesia and neuropathic pain. So what benefits we have from with the use of methadone? It is a long-acting drug, and then it has got higher potency. It can be used. It can confer an additional advantage of relieving the neuropathic pain. It is available in different formulation. The cost is low, so it can be a good option for to use in resource-poor countries like low and middle income countries. It can be used as a co-analgesic, and it has additional advantage of decreased neurotoxicity by conferring the reduced neuroinflammation. What are the different side effects related to methadone? There can be they're similar to other opioids like sedation, nausea, delirium, respiratory depression, constipation, and the more potent side effects like QT prolongation and serotonin toxicity. So it is prudent to note that the peak side effects may not happen for around 10 to 30 days, like sedation and respiratory depression, because the drug make it, as we saw, for the longer plasma half-life and the time it takes to achieve the steady state concentration in the body. So one should be careful enough while prescribing the methadone in the settings of treating the frail elderly patients or some patients with hepatic impairment also. So if you see PCF, it says the contraindications are non-absolute if titrated carefully against the patient's need, but we are certainly are having some of the contraindications or maybe settings where we have to be more cautious. We will be seeing them in details in coming slides. But certain cautions have to be followed, that the physician should be fully aware of the methadone pharmacology. Close monitoring of the patient when starting on methadone, particularly when switching from a high dose of another strong opioid. Slow titration and close monitoring of the patient when changing the dose of methadone should be warranted, and warning for the patients and their relatives that not to exceed the prescribed dose should be given. So here is a comparison between methadone and morphine. So with respect to the receptors affected in the brain, methadone has got agonist action on the mu and delta opioid receptors, and it has a competitive antagonist action on NMDA receptors, while morphine is a pure mu receptor agonist. Methadone is comparably more potent, and there is less risk of tolerance susceptibility. There are no active metabolites for methadone, and the renal adjustment is not needed as such as compared to the morphine. So contraindications we will be seeing in detail, but a few of the contraindications are basically similar, like respiratory depression or CNS depression. The cost, methadone becomes relatively inexpensive as compared to the morphine, and side effects like constipation, nausea, vomiting are relatively less commonly experienced with methadone as compared to the morphine. Also, compared to morphine, methadone has got a higher level of receptor internalization, beta arrestin recruitment, little or no stimulation effect on sodium potassium ATPase activities. Some of the properties which are again similar to the fentanyl, and which through the differential effects on mu opioid receptors, these properties help in having the benefit in opioid switching. The intramuscular methadone is marginally more potent than intramuscular morphine with repeated dosing. Further with it becomes several times more potent, and it gives long-lasting analgesia. There is no single conversion ratio between methadone and morphine. So while switching methadone dose, the effective methadone dose is generally 5 to 10 times smaller than the previous 24-hour morphine dose, which may be still lower in practice, and one should be cautious while finding the initial starting dose of the methadone. So one important topic about methadone and QT prolongation. The normal QT interval in males is less than 430 milliseconds, and in females it is less than 450 milliseconds. So, but the risk of serious complications like serious ventricular arrhythmias, the test D point is the increases with the QT prolongation more than 500 milliseconds, and the incidence is around 3.6%. The mechanism postulated chiefly involve the inhibition of voltage-gated potassium channels, thus delaying the repolarization of myocytes. Use of other concurrent medications we are going to see, which additionally have the inherent property to prolong the QT interval, and there may be bradycardia, which may be contributing secondary to the calcium channel blockade. So risk factors associated include older age, female gender, history of previous cardiac conduction abnormalities in the setting of acute myocardial infarction, heart failure, decreased ejection fraction, liver diseases, use of loop diuretics, particularly to the dyselectrolytemia, and use of other concurrent QT prolonging medications. And in the case of sepsis, the risk of QT prolongation and concurrent use of methadone increases. So this paper about development and is about from James Cell in 2013 is about the development of a development and validation of a risk score to predict the QT interval prolongation in hospitalized patient. So there are certain risk factors like age, gender, then level of potassium, sepsis, heart failure, and they are given points accordingly. As you can see in the chart, and the maximum score is around 21. And the authors they stratifies the score categories with respect to the risk they confer into low, moderate, and high, depending on the risk score of the less than 7 to low of less than 7, moderate 7 to 10, and high as more than 11. As like we saw in the previous chart about the cumulative risk score, depending on the different risk factors. So implication of this is that a risk score using like we saw this clinical variables are easily obtainable, and they predict the patients who are at higher risk of developing the QT prolongation, and this may be useful in guiding and monitoring the treatment decisions. So these are the drugs which with concurrent use with methadone tend to increase the QT interval, like some of the drugs in common practice of palliative medicine: haloperidol, ondansetron, domperidone, fluconazole, clarithromycin, erythromycin, ciprofloxacin, and chlorpromazine. So many of the drugs in common practice. Again, some of the drugs which also being used and help in prolonging the QT with concurrent methadone, like amitriptyline, sertraline. Then we have proton pump inhibitors like omeprazole, and prokinetics like the drugs which are used for nausea vomiting like metoclopramide, other drugs including olanzapine, and loop diuretics like furosemide. So this is the list about the concurrent medication with the use of which in the concurrent setting with methadone, they can tend to increase the QT interval. The risk of cardiac complications of QT interval prolongation must be considered in patient context. Like the ECG monitoring will be largely irrelevant in last days of life, as opposed to the patients with prognosis of several months, for whom it will be appropriate to identify the risk factors for QT interval prolongation and consider doing ECGs and electrolyte monitoring. Means how often we should we should be monitoring this ECG and electrolytes depends on the case-to-case basis and with respect to their prognosis. So basically, it is a with respect to the dosage forms, it is a Schedule 2 control drug. In India, it is available as tablets, 5 milligrams tablets, and oral solution of 5 mg and 5 mg per ml. Outside India, it is available in concentrated solutions or IV formulations also. whatever dosage form it is prudent to ensure the correct formulation, because serious events have occurred with the dispensing of the incorrect formulation. So we saw this in different dosage forms. So it helps to know so about the conversion from other opioids to methadone. There often so there are different formulations of methadone available. There are different formulations of other strong opioids. So there often exists a challenge while converting to methadone with regard to the dosing. No single conversion ratio. If we see in larger practice, morphine is the most commonly prescribed drug for basic for the cancer pain, but there is no single conversion ratio between methadone and morphine, and there is no consensus previously on the most appropriate method for converting an opioid regimen to methadone. So this article by Eric Wong et al. In 2013 about is about the review of common methods to convert morphine to methadone. So this paper mentions about various dosing ratios which have been taken from work of previous authors. If you see Ripamonti group, they gave the morphine to methadone ratio for the initial morphine dose in milligrams per day of 30 to 90. The ratio of morphine to methadone is 4:1. As the daily required of morphine in the patient goes on increasing, the ratio goes on increasing. For 90 to 300, it is 6:1, and for methadone requirement of more than 300 milligrams per day, it is 8:1. If you see other authors and in the morphine dose, if you say they have been a bit aggressive for the lower doses, like they say for the 100 to 300 morphine requirement in milligrams per day, the ratio they have used for morphine to methadone is 5:1, and accordingly they have subsequently given the morphine methadone conversion ratio for higher morphine need per day, like for morphine requirement of maybe 1 gram per day, the ratio goes to 20:1. Then methadone product information itself mentions if there is less than 100 mg per day morphine dose is being utilized, then oral methadone as percentage of the total daily dose of morphine, it should be 20 to 30%, and accordingly they have given the further percentages with respect to the daily morphine dose. So this chart gives the common idea about what should be a conversion ratio for morphine to methadone as per the morphine equivalent daily doses. So there are different strategies which have been shown to while basically there are different approaches while switching from previous stronger opioids to methadone. So first approach is stop and start, that is a Friedman method. In this method, the morphine is abruptly stopped, and it is switched to the regular dose of the methadone based on the conversion ratio. So discontinue the previous opioid, and suppose if a patient is receiving less than 1 gram of the total daily dose of oral morphine, the aged less than 65 years, the percentage of the total daily dose of oral morphine to be given as methadone in divided doses, it is 10%. In the setting of patient who are receiving less than 1 gram of oral morphine, aged more than 65 years, or patients who are receiving 1 to 2 grams of morphine per day at any age, there's 5% of the total daily dose of oral morphine to be given as the methadone. And then the patients who are receiving more than 2 grams of oral morphine of any age, then 3% of the total daily dose of oral morphine should be given as the methadone in divided doses. Another approach is three-step slow switch method. So the three-step approach is to convert the calculated equianalgesic dose of methadone gradually over 3 days. For example, if you have a patient who is receiving 600 milligrams of morphine over 24 hours, then methadone conversion for 600 milligram of morphine, like we saw in the chart, is 15:1. So methadone dose will be 40 milligrams. And to cover up for the incomplete cross tolerance, we decrease the initial dose for 25%. So it gives us the dose as 30 milligrams of methadone. So in a 3-day switch strategy, which is a phased or slow titration, we introduce morphine, we reduce morphine gradually and introduce methadone slowly. Like on the day 1, we give morphine 400 milligram, methadone 5 milligram every 12 hours. On day 2, we reduce morphine by another 200 milligrams and methadone increment by 5 mg, that is 10 mg per 24 hours. And on day 3, we have stopped morphine and added methadone to its full dose, that is 10 milligrams every 8 hours, equaling the 30 milligrams per day. So this method becomes practical and safe. If you see, the most of the opioid-induced side effects are dose-related, and they will generally improve only partway through the switch, and often within the 24 hours of the first initial 1/3 reduction. A short-acting form of the previous opioid, we couldn't to use it as a breakthrough pain or for the risk reducing in case the anticipated methadone dose proves to be inadequate. Another approach is rapid switch method. And here we start 1/3 of the calculated methadone dose every 8 hours. Gun reducing the dose of the previous opioid dose by 50% and continue simultaneously with the methadone for the first 24 hours. We observe the patient closely and adjust the doses as appropriate. This stable dosing may be achieved in 3 to 5 days, and inpatient supervision is recommended in this approach. Another strategy involves the stop and go PRN approach, where the morphine is abruptly stopped, and for the first week, the PRN doses of methadone are used to establish the regular doses of methadone required thereafter. While prescribing the methadone in opioid-naive patient, the approach of start low and go slow should be exercised. The starting recommended dose is usually between 1 to 5 milligrams per day orally, divided over 12 to 8 hours. The titration in the outpatient setting, the dose can be increased for not more than 5 milligram every 5 to 7 days, depending on the patient's response. So here is the evidence from the systematic reviews on methadone for cancer pain, a Cochrane review by Alexander Nicholson et al. In 2017. So chief implications for practice from this review were for the clinicians managing the cancer pain. It was that methadone is an opioid that has been used for many years to treat the severe cancer pain, although the evidence base from the RCTs is still sparse. If the opioids are not tolerated, it may have a role, providing the issues of dose titration and possible severe adverse effects are considered. There is no information for the use on pediatrics. So that was the chief message for the clinicians with regards to the use of methadone. In March 2021, this another systematic review came for the methadone in pain management from the Verena Hanna. This review reported on the effectiveness of the methadone on the management of pain in relation to a comparison drug. The primary outcome was analgesic effectiveness, and secondary outcome were the side effects and cost. A search they did a search of PubMed, Medline, Embase, and Google Scholar databases. They included a total of the 40 randomized controlled trials, and they compared methadone to morphine and fentanyl. The analgesic effectiveness of methadone was demonstrated in different types of pain, including the post-procedural pain, cancer-related pain, nociceptive, and neuropathic pain. The side effects experienced were generally similar to the comparison drug, and lower cost was a benefit to using methadone. Methadone may also be useful as an adjunct analgesic for adequate pain control, as well as in patients with renal impairment. This study recommended that the additional high-quality large-scale randomized controlled trial evidence is needed to establish the role of methadone as monotherapy or as an adjuvant medication. And expertise with the pharmacokinetics, they also recommended that it should be there it should be solved before the prescribing to the patient, and future trials should standardize the reported outcomes to allow for the meta-analysis. Another review, Cochrane review on methadone for neuropathic pain from McNichol, from the author McNichol et al. The implications for practice from this group were that there is very limited evidence to judge the effectiveness of methadone in neuropathic pain. And for clinician, they said there is insufficient evidence to support or reject the suggestion that the methadone has any efficacy in any neuropathic pain condition. Then this focused review by Marion Lee in 2011, a comprehensive review of the opioid-induced hyperalgesia. So they said that they basically postulated three basic mechanisms for opioid-induced hyperalgesia, like the excitatory neurotransmitter NMDA plays a central role in the development of opioid-induced hyperalgesia. NMDA receptors, when they are inhibited, they prevent the development of tolerance and opioid-induced hyperalgesia. So prolonged administration of any strong opioids, it induces neurotoxicity via the NMDA receptors, mediated apoptotic cell death and in the dorsal horn of the spinal cord. So methadone has been shown to have big NMDA receptor antagonism. Thus, it has been shown that the methadone is effective in reducing the high-dose opioid-induced hyperalgesia. Methadone also shows incomplete cross-tolerance with the opioid receptors, adding additional benefit in the opioid switching or rotation. So with respect to the use of methadone in pediatric cancer pain, it's a good article from Dr. Gayatri Pollard and group about the use of methadone in pediatric cancer pain. And the aim of this study was to describe the pattern of, related to the methadone use and its clinical experience in pediatric cancer pain at a governmental center in Hyderabad, which was one of the center which has been licensed to use methadone in India. This was a retrospective study of medical records of all children under the age group of 18 who had been prescribed methadone from September 9, 2017 to November 19, 2019. They collected the data on analgesic effect, prior and concomitant analgesic treatment, opioid side effects, and handling of the methadone. So main indication was pain uncontrolled by regular opioids. So initial daily dose ranged from 1 to 15 milligrams, and the duration of the treatment ranged from 7 to 7 days, with a median of 50 days. And in this study, no severe side effects were noted. The conclusion drawn was low dose methadone in the treatment of pediatric cancer pain at a low resource cancer center was safe and well tolerated by patients with long treatment durations. It was safely managed and administered with single to double daily dosages. Hence, it was easy for the patients and family to handle, and then it was an affordable treatment option. Next comes the article about methadone in hospice and palliative care patients by Marilyn McPherson et al. In 2019 about the safe and appropriate use of methadone in hospice and palliative care patients. It was an expert consensus paper. So there was a panel of 15 interprofessional hospice and palliative care experts from US and Canada convened in February 2015 to evaluate the American Pain Society methadone recommendations for applicability in the hospice and palliative care settings. The goal was to develop guidelines for the safe and effective management of methadone therapy in hospice and palliative care. This article represents the consensus opinion of the hospice and palliative care experts for methadone use at the end of life, including guidance on appropriate candidates for methadone, detailed in dosing, titration, and monitoring of the patient's response to methadone therapy. So the tables have been beautifully given, and they really summarize the different conditions very well. Like this first table, the patient selection tells about the patient selection for methadone therapy. The potentially appropriate candidates for methadone in hospice and palliative care include the patients with moderate and severe pain which is refractory to other strong opioids, true morphine allergies, significant renal impairment, uh, um, who need a long acting opioid, who have high opioid tolerance, poorly controlled opioid induced adverse effects with other opioids, history of patients who have history of dysphagia, inability to swallow or feeding tube placement. Who are the patients who are potentially inappropriate for the use of methadone in the hospice and palliative care setting? They include the patients who live alone or poor cognitive or with the poor cognitive functioning without a responsible caregiver, lack of knowledge of on the part of practitioner on transfer, history of opioids or medication non-adherence, if there is history of substance misuse or multiple risk factors for methadone toxicity like clinical instability, multiple transitions in care, history of transplant, if there is history of QT interval prolongation, or if they are at a high risk of developing such prolongation, then prognosis less than the projected time which is required to achieve the methadone steady state and a good titration of the methadone dosages. If there is a history of obstructive or central sleep apnea, and this next table summarizes about different precautions and contraindications to the methadone therapy. And if you can see, there are different contraindications they have mentioned about the if there is active or illicit drug use or misuse like of cocaine, amphetamines, heroines, or other opioids. If there is setting of congenital QT syndrome in the family, patient family, or there is in the setting of paralytic alias, methadone is relatively contraindicated in those settings. And some of the contraindications which include the structural heart diseases or electrolyte abnormalities, like with the use of like in the setting of hypokalemia, hypomagnesemia, or with the use of loop diuretics like we saw earlier. And they have exercised to include precaution while safely prescribing the methadone dose in hospice and palliative patients. And here they mention also in the first line about the impaired liver function or liver failure. They have given a detail about how one should monitor the ECG and what action steps should be given in a hospice patient. And they have given different levels of vigilance, like low, moderate, or high, for like for the patients who are used in whom the methadone is being used as having the role of second line use, and the goals of care being comfort measures only. The level of vigilance is low. The ECG, it is recommended to obtain the baseline ECG, then no ECG unless the compelling indication is there, and if ECG is obtained, then we have to follow the further recommendations. Like for moderate level of vigilance, the goals of care would be curative or life prolonging comfort measures only. Then in this setting, the methadone may be having the role as a first line or second line, and they have recommended that discuss the risk and benefit with patient and family in light of the goals of care. Then routine baseline ECG monitoring is still not recommended and may consider ECG depending upon the patient risk status, their wishes, and goals of care. Document informed consent if no ECG is obtained, and if ECG is obtained, then we have to follow the further guidelines. They have given high level of vigilance for patients who have curative goals of care and who have good prognosis, maybe where the methadone is being used as a first line drug for various indication. The baseline they have recommended to obtain a baseline ECG And in case of setting where there are positive risk factors prior QTC more than 450 milliseconds, history suggestive of prior ventricular arrhythmia, then consider baseline ECG. If there are no risk factors, QTC less than 450 milliseconds in the previous year, the recommendation if QTC is more than 500 milliseconds, do not use methadone. If QTC is between 450 to 499 milliseconds, consider alternate opioids. And accordingly, they have given the follow-up ECG guidelines. Also, this paper have added on the pharmacogenetics, and they have said that pharmacogenetics complicates the methadone pharmacokinetics because of the genetic polymorphisms, which may result in a range of variable phenotypes from poor metabolizers to ultra-rapid metabolizers. The CYP2B6 polymorphism occur in a variable ethnic distribution. And this has been associated with numerous allelic variants, including 16 different variants that result in no or calculated or no or reduced CYP to B6 expression and or activity, the higher methadone levels and prolonged elimination. So to conclude, some important consideration would be that the prescriber should be familiar with the methadone pharmacology. The start low and go slow approach should be exercised. We have to monitor the patient closely, obtain ECG when appropriate as indicated, and drug interactions and electrolytes. Not to increase the dose more frequently and avoid prescription of the concurrent drugs that may cause QT interval prolongation. The conversion ratios cannot be used while converting back from the methadone to other opioids. We have to communicate with the patient and the family about the risks and benefit associated with the methadone use. And also, as this drug has been used for the management of the addiction, there is a certain social stigma associated with, and we have to also have to may have to deal with the managing this social stigma. And the last will be the safety is of utmost importance. Thank you.
Thank you, Sachin. It was such an excellent overview of methadone. Prasun, you want to summarize before we will take up the question answer?
Yeah, ma'am, sure. Thank you. Thank you, Sachin, for that wonderful presentation. So methadone, yes, it's not frequently used as a first line, even though there is a recent paper which states that it can be used as first line. So we use methadone when other opioids are usually not effective or the side effects are overwhelming or the patients are not tolerating it. And in Tata Hospital, we specifically use it as a co-analgesic. We have got very less patients who are completely on methadone, but you have many patients who are on methadone as co-analgesic. The only thing is the pharmacological properties of methadone, which makes it very risky, is that it accumulates over time and the long half-life and its potential for QT prolongation, even though there is very less chance of torsade de Pontes. As I'm asked, the anti-emetic to be used with methadone, yes, almost all anti-emetics that we commonly use in our settings can prolong QT prolongation, considering the fact that methadone has got a lower risk of nausea vomiting compared to other strong opioids. The lowest possible dose of the antiemetic as PRN doses would suffice, and it usually settles down in a week or so. Yeah, that's all.
Thank you, Prasun. Thank you very much. So we should have you taken the question answer while you were summarizing?
Yeah, ma'am. There were only 2 questions which I have answered.
Okay. So I just want to say something very, very relevant. That with a great difficulty, we have been able to make it available for pain management in India. But since last almost a year, the pharmaceutical, those who are producing methadone, they are constantly requesting that they want to stop production. This is because people are not using methadone in India. So I know that as Sachin has mentioned, and many of you must be knowing, that there are lot of precautions and lot of side effects But you know, whenever you use first time any medication, it is always going to be there. So the people, those who are using morphine already, they should start using methadone, because methadone, I know there are side effects and there you have to be more vigilant, you have to follow up your patient properly, but it is going to be a very useful analgesic. And as Prasun said, that it is a very good co-analgesic. Although we cannot start right from the beginning, but in a difficult situation like for opioid rotation, a patient is not getting relief with morphine, patient's renal functions are grossly deranged, patient cannot afford fentanyl and renal functions are grossly deranged. I think you should have a habit of using such a cheaper medication. It is absolutely it's like it's very low cost medication, which we all should be learning very well. So it is important that all the people, those who are using morphine, they should start using methadone before pharmaceutical companies, especially the Rusan pharmaceutical, who is making or manufacturing methadone, and always coming up with a threatening that we want to stop production because people are not using in India. I think we should really be concerned about this fact, and we should stop. We should start using methadone frequently. This is I want to say. And before we stop lecture, we close this lecture, I want to request Dr. Shobha, Dr. Vidya, Dr. Jennifer, those who are here, if they want to share their experience, or anyone who wants to share their experience. And if somebody has joined from MNJ, I want to hear from them that what was their experience when they were using for pediatric patients. So we can start with Shobha. Shobha, are you there? Otherwise, Vidya.
Good morning, madam, and thank you very much for that session. Madam, I have used it in difficult pain in Vizag, and because we have it through the foundation, but I still don't have it at the hospital because we are still under the NDPS because of rules in AP. We haven't been able to shift to that, but we are definitely trying. So thank you so much, madam.
I want to add one more thing, that those people, those who are having RMI certificate, it is not required to have a separate license for methadone. Methadone comes under an RMI. If you have a RMI certificate, again, the same procedure that you will have to inform drug controller of your state that we want to procure methadone for pain management, and that's all. So
yes, madam. So we do have an RMI through the foundation that I work with. So when I need methadone, we use it from there. So patients are admitted in the hospice, and that's how we transition and give them.
Yeah. So Dr. Jennifer and Dr. Jennifer has already written to me that although she does not have any practical experience, but Dr. Jennifer, would you like to add? Yes, yeah, please go ahead.
Yes, ma'am. I spoke. I'm eagerly looking forward to procuring it. I spoke to the Rosan, those pharmacology people also. So they don't have tablet at the moment. My small concern is with very small doses of methadone and with the syrup formulation, it comes in a way you have to give very, very small little ml of the syrup. So I want, and with a small therapeutic window, what is the safety of it? I actually want to hear from people who have used syrups, because in India, people with syrups, they either with Gelusil or with cough syrups, they do not stick so much with the ml that is prescribed. So have people who have used methadone syrups, have they found any difficulties, people overusing it, any problems? So that is, I'm really waiting for them to start tablet manufacturing to procure it.
So Dr. Jennifer, for this answer is that although it's only syrup available, but we should start using syrup. Once we will have enough utilization of syrup, we can request them to make the tablets. So if they will make the tablets and only one CMC Vellore will purchase, it will be again a problem. And for as far as our experience of methadone syrup is concerned, what we used to do, we used to admit all these patients where we admit all these patients where we use methadone, and then after a lot of explanation and guidance, we send them with the little, we don't prescribe for 15 days, for 20 days, for 100, for 30 days, but for a week or so, we prescribe for methadone to all these patients, those who are going home, and then they will have come and collect it again. Although your concern is absolutely right, people take three teaspoonful, two spoonful. This is the habit of all over India. So it may be, there are chances that people can misuse it. Prasun, yes,
Ma'am,
please
yeah.
go ahead.
Yeah, ma'am. So for quite some time, the tablets are not available, and so we are using the syrup method on the oral form. So it actually comes in a 150 ml bottle, and which costs around like 500 rupees in Tata Memorial Hospital. And the formulation itself contains a dropper. It has a dropper with markings in it. So 1 ml of the syrup which we have from Rusan contains 5 milligram. So as a co-analgesic, we usually start with 2.5 milligram BD or OD depending upon the situation, and then titrate upwards. So when we
Exactly.
explain the patient that half ml, half of a ml, which is there in that dropper, and it can be easily calculated. And if we show them and mark them how much they have to give, and yeah, we have found it pretty useful, and people do not take overdose for that, because it comes with that dropper, so they know that exactly this much, and we give the attender a caution that it should not be a point up and it should not be a point down. So they actually adhere to it, and we have used it in quite a number of patients now.
So now there are two questions. One is,
Thank you.
so this is absolutely right, Dr. Jennifer, that there is a dropper, and dropper really calculate well, so we can explain them properly. One question, somebody has raised their hand.
Can
Who has
I
raised
get a word, ma'am? Dr.
Yeah,
Meenakshi.
please go.
Good morning, ma'am.
Yeah,
Just
Meenakshi,
because, yes, ma'am, I've been using methadone from 2019. I have at least 20 patients. I've prescribed it right from the age of 2 to about 60, and with all the precautions that have been mentioned. And two things I wanted to add here. One, I do not prescribe methadone. I started with IP. Now I do OP and in home care also. And second thing is, I do not prescribe methadone if I don't have a responsible caregiver who is willing to be in touch with us on at least every 3 days on the telephone, and are willing to come and take a refill every 15 days. We've never had a mortality or side effects attributable to methadone initiation. And what we found was, with the dropper, it was very tricky for patients. So we use a 2 ml syringe, which is a little more user friendly than that dropper. So because it's a very tall bottle, so we normally divide the doses and slowly give it in a smaller bottle, from where they can extract in a 2 ml syringe, and with the clear understanding that it's only for oral use, not for intravenous or intramuscular use. And we also tell them that we indicate in their card that this patient is on methadone, and that nobody should give any medications without our prior knowledge. Just wanted to add these points, ma'am. Thank you.
Absolutely, Meenakshi, such a wonderful comments and absolutely useful comments you have given, that it is important that if a sensible or a relative or a caregiver is there, that you can explain, and your life is very easy. And this is also important that whenever we are prescribing, we prescribe for short duration, and also we will say that any medication, if they want to take or they are taking, they have to inform or they have to consult before starting. So it is again absolutely wonderful to use this medication. And one question is there, that whether we can use in private practice. So Dr. Neetu, we can use, but again, same precautions. You have to be very vigilant. You have to follow.
Ma'am, you got muted.
Sorry. So again, we can use it, but same precautions. And if you can practice all these precautions and all the monitoring, if you can do in your private practice, you can use it. There is no problem. But again, this is monitoring, and vigilance is very important to start more methadone and to follow up the patient. So if there are no comments, we are 7:29. We have started exactly at 6:30. So we will stop here. I can't see any other comments. So Prasun has given a very good article. So please follow this article published in Journal of Pain and Symptom Management. Thank you very much for joining, and see you next week on Monday before 6:30. Thanks a lot. Thank you, Prasun, and thank you, Sachin.